Welcome. We're going to get started in 1 minute. Welcome to this Schneps Media webinar, a courageous conversation about race, ethnicity, culture, and health in America. It's time for transformative action to eliminate healthcare disparities. We're going to get started just in 1 moment with Sheila Thorne here. So it's 1 o'clock. Thanks everyone for joining. And we're going to kick it off right now. Hello and welcome everyone to this courageous conversation about race, ethnicity, culture, and health in America. It's time for transformative action. We are getting started right now. This webinar is a Schneps Media webinar. It is recorded so you can watch it again and again, and you can share it with your community, family, and friends. Thank you to our live audience for joining today. Although we can't hear your voice, we would love to hear from you. So please ask questions using the chat or the Q&A function at the bottom of the screen, and we will save some time at the end to get to as many of your questions as possible. My name is Sky. I work with Schneps Media, the largest local media company in the New York metro area. We publish over 70 newspapers, magazines, webinars, and events throughout Queens, Brooklyn, Manhattan, the Bronx, Westchester, Long Island, and Philadelphia. This webinar is being recorded and can be accessed on our YouTube channel at youtube.com/SchnepsMedia. Today's webinar is entitled A Courageous Conversation About Race, Ethnicity, Culture, and Health in America. It's time for transformative action. And the goal of today's discussion is to enlighten healthcare stakeholders about the moral, scientific, and business imperative to weave multiculturalism in their outreach, engagement, and promotional patient education initiatives. As we've all seen, the COVID-19 pandemic illuminated racial and ethnic healthcare disparities, which are compounded by historical mistrust and distrust of the US healthcare system and healthcare providers by communities of color. It's time to move from awareness to action in striving for health equity, and it's the best time to do it right now. I was just talking with Sheila about it, and it's true, and I have her with me today. Sheila Thorne, the president and CEO of the Multicultural Healthcare Marketing Group, who will share best outreach and engagement practices for partnering with diverse patient advocacy groups, as well as discuss why this hasn't gotten traction over the decades. We will learn how Sheila approaches this problem with her clients and how companies can succeed by investing in her methodology. So again, for those of you watching live, you can use the Q&A function at the bottom of the screen to pose any questions you have, and we'll save some time at the end to talk to Sheila about your questions. But right now I want to kick it off with Sheila Thorne and have her introduce herself and tell us about her background and how she enhances businesses through cultural competency training. So welcome, Sheila Thorne.
Thank you, Sky. It is a pleasure to be here. And I am so thankful for Schneps Media in their willingness to talk about a subject that makes most people uncomfortable, and that's race and health. I'm president and CEO of the Multicultural Healthcare Marketing Group. I know that's a mouthful. We call it MHMG. And we spend our days and our weeks and our months and our years, as we have for the last 2 decades, helping organizations and companies do a more effective job in reaching out to people of African, Hispanic, Latino, Asian, and Native American descent. We predominantly work for pharmaceutical companies, but we also work for not-for-profit health organizations, for hospital systems, for payers, for group practices, ethnic medical societies. It's all about health. We really focus on that because clearly these populations have long had disproportionate impact of disease, illness, and premature death. So my team is all of color. Half of us are multilingual. We are in culture. We're in community. We are community. So we understand the environment that patients that don't look like you, don't sound like you, don't come from where you come from, how they think about health and how they feel about Western medicine or alternative medicine, how to navigate the system. It's a very complex environment, but that's our focus. We want to hear the patient. We want to understand the patient experience and the patient voice. That's what we do first, and helping our clients to really weave multiculturalism in their promotional work, their educational materials, and all that they do regarding keeping people healthy.
So it's a hot topic. It's top of mind for a lot of people, but healthcare disparities are nothing new. So why, Sheila, do you think there's such a focus on it now?
Yeah, it's certainly been around a long time. The first time the government documented that these disparities existed was in 1985, Sky. So this isn't a new phenomenon. And that report about Black and minority health was about 3,000 pages, and it documented that people of color are not receiving quality care and not benefiting from biomedical research. Fast forward to 2002, there was a report by the National Academy of Sciences, the Institute of Medicine, Unequal Treatment, Confronting Racial and Ethnic Disparities in Health. The data are the same. And even with this study, it was with insured, middle class people of color. So in that case, poverty and insurance was not the issue. So why don't people really grasp this and really take it seriously? It's challenging. Many of these organizations don't have people who look like me. So they're uncomfortable going into these markets and they don't want to do the wrong thing. They have a good intention, but they're tactically challenged. They don't know how to engage and communicate, and more importantly, sustain engagement with these groups so that it's a continual journey so that people can take charge and control of their health. But it's getting better. It's certainly not as good as it should be, but it's better than it's been.
So how has your work evolved over the years?
That's a great question, because when I first started doing this work, it was really more from a philanthropic perspective that the companies would take. It was housed in corporate communications or with the foundations of the companies. And that's not a bad place, but unfortunately, budgets in that arena are small and the sustainability is challenging and the grant process is cumbersome. But really, when you moved forward in time in the early 2000s, it started to shift to the business side of the ledger with regards to for-profit companies. And with not-for-profit companies, they saw that there was a need to partner with these groups to do a better job. So the evolution has gone from a social, philanthropic, humanistic perspective to a business imperative, because the numbers in these populations are growing exponentially. So you really have to ask yourself, who is your customer? Who is walking in the doors of your facility? Who are you charged with reaching out to so that people don't get sick? And if they do, early detection and then treatment kicks in. So it's a challenging dynamic. HR does one piece, but that's not the piece that's going to sustain. You may get the right people who look the right way in the room, but you've got to do more than that to reach these populations.
You make a lot of good points. I'm wondering, if someone wants to work with you, how would that work?
With a variety of ways. We obviously are a small boutique shop, and I have had many wonderful experiences working with extraordinary professionals in the major, large agencies. So we bring a specific expertise. So we partner very often with those agencies to help enhance what they're trying to do in the racial and ethnic segments. But sometimes companies come to us directly in terms of a specific project or program. And we work in that way on many different levels, depending upon the disease state. Here lately, the one area that we've gotten a lot of interest in is that increasing diversity in clinical trials. As you said in your opening, COVID-19 has glaringly illuminated the fact that these groups have more disease, more infections, more hospitalizations, and more deaths. So the disparities conversation has certainly come back to the front burner. And so companies come to us in a variety of ways, depending upon their need, the disease state, and the target ethnic segment they want to reach.
So how, with clinical trials, that's with a pharmaceutical company. So how does your work differ working with pharma versus working with nonprofit, for example?
Well, yeah, I mean, certainly pharmaceutical companies produce 75% of their clinical trials are funded and sponsored by pharmaceutical companies, and sometimes in collaboration with government agencies as well. And our work really, hopefully, starts with the protocol development. What do you want this clinical trial to help you find? What are the outcomes? We don't often get called in on that level, although that's where we really would like to be, because sometimes the inclusion-exclusion criteria of these trials makes it very prohibitive for people of color to get involved. But most often, Sky, they call us when they get in trouble. They call us when they definitely want to reach these populations and they haven't had much success. And clearly, clinical trials are very expensive and they're very complicated. And sometimes the deadlines in order to really get this trial up and running is daunting. So they'll often call us to help them find the patient advocacy groups, find the critical pockets of community people, and help them to understand exactly some of the issues and unique concerns that these potential participants have with clinical trials.
And what is the key to success when it comes to increasing diversity in these clinical trials? Like you said, there was a big hesitancy, especially now with the vaccine and COVID.
Right. Mm-hmm.
So what is the key to debunking that really for that community?
Yeah, the historical medical abuse and experimentation that these populations have experienced is longstanding. And unfortunately, that's created mistrust and distrust that is very much embedded in the population itself. People often say it's the Tuskegee syphilis experiment, which is probably one of the clinical trial abuses that we know. It's certainly not the worst, but it's one. It's not just that. There's more to it than that. It's the fact that these populations are often not asked to be a part of clinical trials. And when they are potentially participants, nobody explains to them what this trial means, what the responsibility is, what the requirements are. So there needs to be a huge amount of education. But here's the key to success. With the right messenger, you can reach these populations. You've got to find the voice, find the trusted entity, whether individual or organizational, to walk in the room with you or walk in that neighborhood or that community with you to allay the concerns of these groups. Not many of them know that immediately after Tuskegee, there were governmental safeguards that were put in place that still exist today to protect anyone who would volunteer for a clinical trial. But that's no guarantee. That's not a slam dunk, but you've got to start with education and explaining to people, what's it like being in a clinical trial? How is it going to affect my family life? How is it going to affect my job or my professional life and my children and my lifestyle? Those are a lot of the real concerns. What is it going to cost? How much time is this going to take? So I think sponsors of pharmaceutical companies and government agencies have to really spend a little time getting in community, boots on the ground, talking to people, meeting them where they're at. And then once you know those concerns, proactively address them, be it cost, childcare, elder care, transportation, whatever that may be, to lessen the burden of being in a clinical trial. So the patient will not only volunteer, but stay in the trial.
I'm just thinking still about COVID and the vaccine and all the messaging and the commercials and the ads on the subway. Do you think that was well executed in the way that the city and the state went about doing that?
Well, yeah, I mean, you've got to use media and you've got to use high tech. Obviously, COVID presented some barriers to really getting in the face of the community. So my saying, Sky, always is high tech gets their attention, high touch makes it work. So once you have that noise in the media and you have those ads and those posters and the radio PSAs and the commercials, that's great stuff. But then you really got to get down on the ground. You've got to find whether it's a faith leader, whether it's a community activist, who is trusted in that community. And I think you may have seen in the media, as many of our guests today, people went door to door. They went church to church. They went to barbershops. They went to beauty salons. They went to businesses. Anything in the community where you could have some kind of personal interaction and ask questions. And the hesitancy is still there, but it's gotten better. And many people ask, well, how many people of color were in those clinical trials for the vaccines? They didn't really match the proportionate percentage of the people of color in those trials, but they got close. So we have the confidence that there were numbers of people of African, Hispanic, Latino, Asian, and Native American descent in these trials. It wasn't a home run, but it was certainly closer than it's ever been before in my experience in working on clinical trials. I've worked on 14 clinical trials that were looking to increase diversity. I've worked on 4 race-specific trials for Blacks and Latinos, and it's challenging. The materials have to look different. Certainly the messenger, as I said, has to be different. And the implementation. One of the most daunting parts of a clinical trial is that informed consent document that every participant must sign, giving them all of what's the good and the bad, all of the side effects, everything about that trial. Did you know some of them are 40 or 50 pages long? And to have someone sit and go through that medical language and complicated vocabulary is challenging. But many of the clinical teams are getting better at doing that and sitting with that potential participant and a family member and an advisor, a pastor, or a lawyer, somebody that can help them wade through that document. Always with the caveat that if they do volunteer, they're eligible, they pass all the tests, they still have the option to drop out at any time with no penalty or no consequences. So that's what I'm talking about education. What's the day in the life of somebody in a clinical trial look like? From getting up in the morning, getting your kids off to school, going to work, and maybe having to leave and go to a certain site to have some conversation with the clinical team. And now, of course, with COVID, you really can't do that very often. So there are some kinds of trials that are being developed where the trial comes to you with a visiting nurse, or maybe technology that you can do it online. So we're really being forced to develop more creative ways of making participation in trials less burdensome. So again, it's all about education, and it's all about the relationships with people who look like the trial participants, who may come from where they come from, and obviously who may speak the language. And so it's a challenging dynamic, but it's doable.
It's like a campaign, like
Yeah,
engaging the proper stakeholders in the community to access more people.
exactly right. And clearly the back end of it is you've got to go back to those communities and tell them what the results were. So often when the trial is over, the clinical researchers and the scientists may or may not be happy with the outcomes, but they leave. They don't tell the community or those who were courageous enough to sign up what it meant. It helped you, maybe it helped a family member, and maybe it even helped your community. And that seems to be an attractive part of these clinical trials as well. It's going to help the overall health of people who look like them, who speak like them, and may come from where they come from.
So you think that's the biggest hesitancy for people of color to get involved in clinical trials or to put themselves out there?
Yeah, you've got to get through that mistrust, distrust. And that's hopefully by virtue of knowledge, of education, of really explaining to people what it's all about. That's not necessarily something that is done in 24 hours. That's a continuous journey. That's a constant conversation and dialogue. You know, for example, I mean, we're living at a time when people are going through severe anxiety, fear, and trepidation with this COVID vaccine or this COVID environment. And that's challenging. And so we clearly have to go the extra mile to help those who may be eligible for these trials to know that what they're doing is just about good medicine. It's just about good science. You cannot keep extrapolating medical data from white middle-aged men. No disrespect intended. You can't keep doing that and think that the drug is going to be safe and effective in everybody. So it's definitely a scientific imperative so that we have the best health and the best quality health. And that's one of the ways you're going to achieve health equity. So everybody can have access to the best possible treatment to get the best health outcomes for them.
Yeah, you have a wealth of knowledge, and I want to encourage anyone who's watching live to please submit some questions if you have for Sheila, and we'll take them at the end of the conversation. But Sheila, I'd love for you to really tell everyone your story, the story that you told me of how you got involved in this in the first place.
Yeah, it is a story, and I often reflect on it myself. I mean, I was a junior high school French teacher. I taught middle school for 7 years and high school for 4 years in New York and Connecticut. And I think, Sky, that was probably the beginning, because a language is a vehicle of culture. So I knew that people, even though they said things differently, they also had a different life. So I love teaching. I loved children, and I love being a part of their development. In fact, I still say I teach. The kids are just bigger now. But at that time, my mom was a nurse. My sister was a nurse. So I think I got the healthcare by osmosis. And clearly, health was always important in my family. Born in the South Bronx, what they call the Boogie Down Bronx, raised in the North Bronx. And certainly, as a native New Yorker, I was always confronted with diversity in my family. And so that was never an issue for me when growing up. But when I decided to leave teaching, I thought that I could use my languages as a way to get into the business world. So I worked with fashion houses, I worked with banks, I worked with anything of an international concern, because I could read and understand Spanish, I could speak Italian, so I was multilingual. Even this Black girl from the South Bronx. So, but the one entity that attracted me was the marketing and public relations part of the business world. And I then began working for small agencies to kind of learn the tricks of the trade. I wasn't educated in this. So I work with small shops. I work with some French public relations companies and did a variety of things. I did cars, dolls, and cake mixes. You know, it was just all about general marketing. But Sky, the healthcare clients, the pharmaceutical companies really pressed my buttons. So I was reading JAMA in the New England Journal.
Yeah.
I was comfortable talking to doctors. And so I kind of gravitated into that specialty. And when I got to a certain level in the advertising and public relations world, I kept putting it on the table to the clients that would walk in the door. Why aren't you talking to Latinos about type 2 diabetes, or to Asian Americans about hepatitis, and Blacks about heart disease and hypertension? And they would kind of look at me strangely and not kind of say, well, those people are sick because they're poor. I said, really? I think there's some of them that are not poor. We're going to take care of those that do have a financial issue. But I started challenging them. I started saying, why don't we do some programs and just try it? And again, once they did, they saw the benefit. So, you know, it began to be my specialty. HIV was next, and heart disease and respiratory disease and cancer, prostate, breast, lung, colorectal. All of these diseases, these groups over-index and die disproportionately at a much younger age. So I decided to get into the agency world and was able to have the privilege of working with a number of agencies where there were extraordinary professionals who got it. They heard me, they listened, and encouraged me to do the work I was doing. I lived in Europe for 6 years and did some multinational programs, and I've worked on the ground in 5 countries in Latin America. So I understand the immigrant population, because when those folks come here, they're 3 and 4 generations in the same house. So I then decided in 2002, as I said in the beginning, that I really needed to focus on this. I saw the census numbers change, Sky. I saw these populations were burgeoning in urban centers where most companies make most of their money, and many voluntary health associations, nonprofits, were struggling with how to reach these populations. So I pulled my team together, and as a result, that's what we do. And clearly that has been my joy, and also professionally, a very exciting time for this country to come to terms with its diversity. And there's still challenge with it, but I'm determined to shift the paradigm of how these groups think about communities of color. And therein lies why I started cultural competency educational programs. You and I talked about that, remember? I don't do diversity training. That's transactional. That's EEOC, that's affirmative action, that's compliance, and that's important. I do diversity education. That's transformative. That changes hearts and minds. Training is like a skill set. Of course, you do learn some skills in education, but you got to understand these populations first. You can't just jump in there and think with your pilot program, you're going to change the world. You need much more of a commitment. So that's my plea to the not-for-profit groups and the for-profit companies I work for. You're in this for the long haul, or don't bother.
Right. So repeat what you said again. It's not diversity and inclusion training.
Right. It's not that.
It's cultural competency.
It's cultural competency, cultural education. And that term cultural competency only came about, oh gosh, in the last 2 decades. And it's been around a long time too, but it really came to the fore when those demographic shifts started happening. And then researchers, clinicians realized that culture was a significant driver of behavior and attitude. So now you've got to understand culture. And that's more challenging. And that now has become the norm. A lot of people don't like that term competency, because if you don't know these cultures, nobody wants to be called incompetent. So I use cultural proficiency. I work with extraordinarily highly educated people in my work, and certainly they have well-traveled, they're sophisticated, but you know what? They don't know this, okay? They don't know culture. It's never been something part of their education. Whatever they know is from personal experience. That's not good enough. You really have to understand where these groups come from, where they are now, and as far as health is concerned, where they need to go. So I do diversity education, cultural competency education, and certainly that really lays the foundation. If you know those things, if you know best practices, then you know how to put a campaign together. You know what language to use. You know what media vehicles to use. You know who are the key spokespersons. So all of that is based on education.
Mm-hmm. So how do you measure your success when you work with these organizations?
That's probably the most challenging part of it, because in the for-profit world, measurement, they like to see measurement happen quickly. They want more market share. They want to move more product. They want more prescriptions, and there's nothing wrong with that. However, when you don't have the relationships in the community that are needed, that takes a bit longer to achieve. So I do qualitative and quantitative. The qualitative is, do you have new partners? Do you have new messengers? Do you have new physicians that you can call upon who look like these populations, especially those who may treat large numbers of people of color? From the quantitative perspective, it can run the gamut. How many people came to the event? How many people responded to the 800 number? How many people hit your website? You know, those numbers you definitely can get technologically, but it's the qualitative piece that's going to help people understand the dynamic of, is this product good for me? And if it is, will my doctor give it to me? Will my insurance company reimburse for it? So, the line from campaign to sale is not straight. It goes up and down, because healthcare is a very complex ecosystem until you can really measure. But I think my key message to my client is, it's not going to happen in 90 days. It's not going to happen with a pilot project. And I don't really use that term. I call it the first city of a national rollout. Okay. So let's go where we can test some things and learn some things, and then take it from there to another city. So you think global, but you act local.
Right. Are there any companies either that you're working with or that you could point to maybe that are doing a good job of this multicultural marketing, outreach, and engagement?
Well, it depends on how you define good. There are a number of companies that are playing with this, and I use that term not disrespectfully, but they're not serious. You know, they'll do a little program, and it may work well, but it's usually driven by a champion within the company and the organization who gets this. And it's not necessarily the person of color, somebody that's just a visionary, somebody that just sees there's an opportunity here. And unfortunately, when that person may leave or move on, it kind of dies on the vine. Okay, so we've got to figure out a way to weave this concept, this philosophical approach, this strategic approach throughout the team, so that regardless of who's at the helm, it's on the table. You may not necessarily do it every time for every product, but there may be some where you have a distinct competitive advantage. And once you get that low-hanging fruit, that's where you go. So again, that's the challenge in the measurement. There are a number of case studies out there where this has worked. We don't have to keep reinventing the wheel. There are a number of organizations that are doing excellent work in the community. Don't create a new program, partner with them. Give them the resources they don't have, the exposure that they might need, and it's a win, especially if they have a following. So my approach is always strategic. Don't have to go from ground zero to 60. There's already stuff going on. You just need to do your homework to find those things.
Is that what you would point to say that's been your most success? Like, how do you measure your success in doing this with clients?
Well, and again, I think the qualitative is what my team and I talk about the most. We make a difference. We get the feedback from the community that they learned something, that they've changed their eating, they've changed their diet, they go more to their doctor. So with us, it's about people. It's about the patient. And if the patient does respond and gets to a better place with their own health or their family's health, to me, that's success. I win. With regard to the client, it just depends on the number of patients they want to reach and what time frame. So I always want to have the business analytics people in the room. Where are you doing well with your product? Or where are you doing well with your campaign if you're a not-for-profit organization? Are people getting it? That lupus and migraine and multiple myeloma, some of those orphan diseases are hitting these populations the most. Are people finding out how to handle that? So we work on a number of projects, and the success is based on the resources, the target audience, and also the ability to connect with community groups. So, and it's gradual, okay? After an event, after 3 months, go back and do a survey. Did people remember you were there and what you did? Maybe another 6 months. And by the way, I do top down and bottom up. I talk to the healthcare professionals, physician, nurse practitioner, physician assistant, even the pharmacist, because those are the people in the community where people might go first to find out what they need. So I don't leave anybody out. So the professionals of color or not have to be educated about the population, and the consumer, the patient, the caregiver, the family has to be told. So it's top down, bottom up, and in the middle, you got a success.
Wow, look at all this information. I see some questions are coming in. So anyone out there, if you have questions, we will get to them. And this question, Sheila, says, how should smaller pharma companies approach diverse populations for clinical trials and treatment protocols if they are resource constrained?
That's a great question, and it often comes up. I guess my first suggestion would be to target a geographic area, a small geographic area where there's a catchment of these populations. Maybe it's a Philadelphia if you want African Americans. Maybe it's Fort Worth in Texas. Find a small entity where you can measure not only the number of providers, but the critical mass of the population. And then look for partners. Go into those communities and find out who's already doing something in the arena you're interested in. You may not know. I ask usually 5 people, certainly the hospital personnel, the ethnic or the physician or healthcare professional society, and then you go on to the community leaders. You know, who's really doing something in this area? So I guess my answer to that question is you've got to be strategic and you've got to be realistic, given your resources, both money and human, to choose a small market to start with and build from that.
Mm-hmm. There's a question here about partisan media, which we love talking about. With the increased proliferation and accessibility of partisan media that often provides misinformation for the sake of ratings, how do multicultural advocates and educators in healthcare work around or past this new era of exploitation and dangerous miseducation?
Yeah, it's tough. It's very tough. And I think I alluded to that in the beginning, that we're living in a very toxic environment where misinformation is pervasive. And what I do when we work with community groups is try to help them understand and look up the origins of these sources of information. Who are you getting this from? Are you getting it from TikTok, Instagram, and all that stuff? Or are you looking at the websites of NIH and CDC and Pharma? We try to guide people to trusted resources. And often they're challenging too, because information changes. This is dynamic. There's no definitive answer. As we have all seen with COVID, things change from day to day. So I guess my answer is, to the extent possible, build up the credibility of trusted sources and minimize all of that misinformation, and even go to the point where you have messengers who are going to say, that's not a healthcare resource you can trust. And here's why. I mean, it's difficult because people are on social media 24/7 today. And when we're locked down, we even depend more on media. You've got to push those trusted sources, and also the ethnic trusted sources. Black newspapers, Hispanic newspapers, radio is a huge medium to get information out and dispel the conspiracy theories and the misinformation. It's not any one thing. It's a constellation of things that you have to pull together and stay in the face of the community. Posters, barbershops, beauty salons, flyers. You've got to bombard them with correct information. And even we've done, Sky, fake news versus the facts. With regards to some health information. Just list all the things you know they're reading on social media, and then dispel it on another column and give a source. So, printed, radio, all of those vehicles are going to help you to keep hitting that message frequently, regularly, and clearly with the messenger who they trust.
It sounds like a lot of work to do. It's overwhelming almost, the amount of touch points that you have to make in the community.
Yeah, it is. It may be overwhelming to people who've never done it before. Okay, but when you're in community, you know those touch points, and you may not be able to hit all of them, but you can hit most of them. I want to hear it in church, or whatever my faith institution is. I want to talk about it, in the health ministry. I want to talk about it in the barbershop, the beauty salon. You've got to get around that, and I call it surround sound. Yeah. Okay, you've got to saturate whatever media there are. Posters in bus shelters, flyers in laundromats, And certainly using check cashing stores. I've done programs in check cashing stores. You know, they often call them ethnic banks. Everybody goes there if they don't have a bank account to cash their check, to pay their utilities, to get their lotto card. So one check cashing store across the street from a hospital in a major city sees 10,000 people a month. Wow. I mean, you've got exposure there. Give them a flyer. I've even done programs in food banks. As people come to get their food, have a pamphlet you can put in that bag or have a flyer. Not a lot of words, a lot of pictures, real simple, and you can hit that person. And that helps a lot. I use students in community colleges to go around and distribute flyers and talk to people. I train them, I talk to them. They go in the beauty salons and the nail salons and the bodegas and the Korean businesses. They're the ones that look like the community. They speak the language, and they often don't even need to be paid. It's nice when you can pay them, but sometimes they do it for college credit. You've got to be creative.
Right.
You can't just use the same old, because it's not getting to folks. You've
Right.
got to really dig into the community and meet people where they are.
Yeah, it takes an out of the box creative thinker such as yourself, which you've obviously demonstrated to everyone that you are.
Well, and that's really what's been the joy, because you've got to think it through. You know, some of the information is very difficult to comprehend. So how do you do that? And obviously with the pharmaceutical industry, is it a branded or unbranded program? Do you talk about your product or you just talk about the disease state? Those are business decisions that you make internally with the team. Obviously, the industry is heavily scrutinized and highly regulated. So you can't just do anything. You've got to do what works. And with regards to not-for-profit organizations, you're selling ideas. You don't want to get type 2 diabetes, you got to exercise more. You got to change your diet. Okay. So there are certain lifestyle things you have to do that the community can relate to, but don't give them a brochure of food that they're not comfortable with or that's not their preference. We did a program with the Asian Indian community, and this clinical trial, you couldn't eat fried, greasy, or spicy food. Well, all these communities eat very spicy food. So you can't tell somebody for the duration of this trial, you've got to eat yogurt. So you get an Asian Indian registered dietitian to say, what can you help me give these what are the recipes so they can enjoy their food, but still won't in any way affect the trial. So it is a heavy lift for some people. You've got to get the right partners. That makes it easier. And here's the other thing. When you do it once, you got them. So if you do it once with cancer, you've got those ambassadors, you've got those relationships, you can come back and do diabetes, you can come back and do HIV. Keep the dialogue going about health. Don't just drop off the radar screen, because it's going to cost more and take longer to get them back in the loop of thinking about health.
Right, it makes sense. Now, do you think overall this industry has made progress towards a campaign like what you're describing?
Well, they certainly have done a lot better. When the direct-to-patient movement happened in marketing and media, the focus shifted from the physician to the patient. And I think many groups, many companies, many not-for-profit groups really started to listen to the patient voice, regardless of what that voice was. So it is better. But the amount of money that is given to programs for these target audiences is highly underfunded. You need to have funding and resources commensurate with the problem. And you can't expect minimal return. You can't expect maximum return with minimal investment. And it's not a cost, it's an investment. Are you invested in improving the quality of health of these populations so that all Americans can achieve equity? So you got to really think about it. And budgets are real. You know, it's restrictive. You don't have a bottomless pit, even though many people think the pharma industry does. They don't have, excessive money that's just hanging around, but you really have to be more creative and get the right partners to walk with you and say, okay, what's the most cost-effective way to achieve this objective? And how can we keep this going, even to a minimal extent? Once you get the big piece going, how can you keep it going?
Yeah, these are all good things to think about. And again, anyone out there that has any questions, please submit them. There's another question here. From what you say, it sounds like commitment and having the capacity to genuinely listen to people experiencing disparities will help bring about change. What additional qualities are needed for someone like myself, who is a new nurse in the healthcare field, to bring about change and minimize healthcare disparities?
one patient at a time. When I talk to healthcare professionals, like this individual who gave the question, the passion is there, the commitment is there. Sometimes institutionally, they get pushed back and they don't always get the support that they need to do what they do. My suggestion always is do what you can, one patient at a time, and hopefully build that in that patient to reach out to other family members or community people. And I tell you, once they find out this nurse goes the extra mile, the word will spread and they'll come. So you've got to work within your limitations, but don't give up, because now is the time. And I think I shared this with you, Sky. There's nothing more powerful than an idea his time has come. As you said in the title, it's time. It's long overdue. And it's about time all of the stakeholders in healthcare step up to the plate and do their part. No one entity can do it all. Government can't do it all. Big Pharma can't do it all. Community-based groups, not-for-profits, but collectively, they can certainly make a dent. Look what happened with the vaccine. Have you ever seen the kind of global scientific collaboration to come up with a vaccine in a year that normally takes a decade or two? So if you can do that, it can certainly be done on a small level in community.
Right. Do you think, Sheila, that we will ever eliminate healthcare disparities?
That's a great question. And I've asked that all the time. It is elusive. It seems like we take 20 steps forward and then we take 40 back. I think that depending upon the disease state, the disparities have certainly enabled us to close the gap. But there's a lot more work to do. Eliminate, that's a powerful word. I don't know whether we'll ever get to that point, because there are so many social determinants that drive outcomes and behavior that we don't control. Education, housing, school safety, though, and then of course there's racism, bias, and discrimination. So until we fix some of those things, no matter what we do about disparities, it won't work. So I've got to have a community where I can get fresh fruit and vegetables if I have to eat right. Many communities in this country do not have that. You've heard about food deserts, of food insufficiency. As long as that's a problem, then telling somebody to eat right is not going to ring true. So eliminate, no, but we can certainly reduce, we can certainly make a dent, and we can certainly raise consciousness about patients who really want the best for their families, and we all do. So I think it's aspirational to say eliminate, but it may not be realistic, certainly in my lifetime, but I keep striving for it, one patient at a time.
One patient at a time. And again, if anyone has any questions, we have some time for questions. So please continue to submit your questions. And Sheila, is there anything that we didn't touch on that you wanted to dive into?
Well, one of the things, I was talking to someone earlier today about increasing the number of people of color in the health workforce. And that certainly will go a long way. And clearly that's improved, but it's certainly not nearly what it should be. As a Black woman, it's probably highly unlikely that I'd be able to get a physician or a specialist who's also African American. So there's a lot of talk about whether that's going to make a difference in the quality of my care. And there have been studies at Johns Hopkins and other universities to make sure that race concordance, when you and your doctor are the same, and race discordant, when you and your doctor are different races, does that make a difference? So I think what we didn't touch on is getting more young people to get involved in the biological sciences. So it is possible for me to see a physician that looks like me. And not that the physician who doesn't look like me won't give me good care. It just might take a little longer for me to trust that doctor. So I'm working on a STEM program right now in New Jersey to encourage more young people in marginalized, underserved communities to elect sciences as a career. And again, those are the kinds of things that I think will help people have a better comfort level when they go to an institution, to see folks who look like them, not just people in housekeeping or in the hospital cafeteria, but people that are in the surgical suites, that are in the exam rooms. That then gives them at least a little bit more comfort that they're going to get the right care and in the right directions about their health. So that is very important. I'm not a healthcare professional, but I revere those professionals of color who have succeeded in spite of their obstacles, and there have been many. There are 4 Black medical teaching institutions in this country: Morehouse School of Medicine in Atlanta, Meharry Medical College in Nashville, Howard University in Washington, and Charles R. Drew in Los Angeles that produced significant numbers of physicians of color. And there are also Hispanic serving institutions that have health as a predominant a part of their training. So I think all of us need to, with our young people, even as long as middle school, start talking about opportunities. Doctor is great, but there's a lot more opportunity in the healthcare field than just a physician. As I said, my mom was a nurse, my sister was a nurse. So nurses, physician assistants, nurse practitioners, all of those entities we call physician extenders. You may be more likely to see the NP or the PA than you would your doctor. So we need all of those who look like, sound like this community to help. So anyone listening that has young people that really want to go in the medical field, there are loans available. There are government support available. It's a commitment, but it's certainly well worth the effort so that the population can look to those clinicians with some comfort level.
Mm-hmm. And there's a question that came in as you're talking about that. Any tips for how to search or obtain references for patients interested in having a doctor that looks like them?
Oh, that's an excellent question. There are some payers that are trying to match patients with doctors of color or physicians of color. And they're kind of experimenting with that to see whether it does make a difference. There are no real tips for it, but I think there are large ethnic medical societies, like the National Medical Association represents 50,000 African-American physicians. The National Hispanic Medical Association, almost the same number. The Asian Pacific Islander American Health Forum. I've worked with all these groups for 20 years. I know those key thought leaders. They're practitioners and clinicians who focus on the health of the people who look like them. So they might be resources to find a doctor in your area with the specialty you need. Go on their websites, nmanet.org, nhma.org. Just Google them and you'll find that they may give you some direction or recommendations that you could use if you really want a physician of color. Oral health and mental health are two areas also, Sky, that are not often talked about. And those are often a very significant part of your health. I worked with the National Dental Association, the National Hispanic Dental Association, and one of my best friends says, Sheila, you talk all about this health, but the teeth are in the head, and the head are part of the body. So if you talk about health, you've got to do oral health. The highest number of cavities are among children of color, because of diet and other habits that are not really good. So it's not just the medical world, it's also oral health and mental health practitioners. And by the way, mental health is certainly being stretched to its limits now in COVID-19. Clearly, there are a number of people of color who are frontline workers, EMTs and practitioners, nurses aides, who've been exposed to this virus and certainly have had devastating impact on their health. In fact, there's something they call race-based traumatic stress now. The fact that if you're a person of color, many people of color are suffering from PTSD who've never been on a battlefield because of racism, bias, and discrimination. And now you've got COVID on top of that. So it's daunting. It's really just illuminated problems that have been existing all the time. And we've got to come to terms with that. So oral health, mental health, physiology, technicians. I mean, there's a plethora of opportunities in the healthcare field beyond the doctor. And we need more people who speak another language, who look different and come from someplace else.
Mm-hmm. Another question about the use of telemedicine and telehealth as it's increasing rapidly, especially during the pandemic. Are these tools something that will narrow or widen the gap in marginalized communities in its current state?
It kind of does both. I think it does narrow the gap because it's more accessible in terms of technology and getting to your physician. I talked to some cardiologists recently, and one of them said telehealth worked to a point, but then her patients started saying, I want to see you. I want to come in to visit you. So it works to an extent. It's expedient and it's convenient, so for sure. But then you look at the digital divide and the fact that many of these communities don't have access to not only computers. I have one family I worked with in New Jersey. It was one computer for the whole family. Mm-hmm. So it becomes challenging in terms of cost, not to mention the transmission, the transmission ability. You know, they may not have Wi-Fi, they may not have the internet. I mean, so yes, it can narrow the gap, but in certain rural areas and certain urban communities, it's made it more difficult. But I do think there's hope. I do think it's promising, and obviously it's zoomed to the top of the list because of COVID-19, and it's
Right.
forcing that industry to do a better job.
Mhm.
And also Medicaid and Medicare are still struggling with what they will reimburse with telemedicine and telehealth. So, I mean, in this complex environment, one thing affects another. It's so complex, it's all interconnected. So when you think you fix one piece, it may impact something else. So it's a broad, you've got to think broadly about this.
Right. If anyone else has any questions, please submit them. We have a few minutes left with Sheila Thorne to answer any questions that you may have. Please go on ahead. Is there anything else here, let's see. Anything else, Sheila, that you wanted to cover? I know your website, sheilathorne.com, is how you can reach Sheila.
Right. Yeah, I think the only other piece I would add is the advocacy piece, because many of these patients who are living with chronic or life-threatening disease become self-advocates in terms of speaking up to practitioners or institutions who may not be treating them very well. And often that turns into a broader advocacy component. I have the privilege of working with a number of groups who are trying to develop a better skill set in advocacy. Because as I mentioned, some of this stuff is policy driven. And if that policy is not going to meet your needs, you're stuck with it, and you've got to help change it by talking to legislators. So patient advocacy groups that are surrounding issues of breast cancer, prostate cancer, HIV, which has not gone away. And certainly with pediatric issues with children. Now that we're struggling with that with COVID-19, about vaccines and the age appropriate level of getting vaccines. So in my work and my team's work, we have always focused on being the voice for the voiceless, being the advocate for these patients, because they often don't feel capable of being a voice, and they don't have enough information. So in my opinion, healthcare marketing, multicultural healthcare marketing, must include advocacy as a key component. You've got to fight for these folks because they're dealing with a lot of stuff on a daily basis, paying the rent, going to work, taking care of kids. And now you've put health. So they may want to be an advocate, but they just may not have the capacity to do that. Mm-hmm. So anyone in multicultural healthcare marketing, my feeling and my team expresses that we fight for these patients. We use what we learn from talking to them in our conversations with not-for-profit organizations or with for-profit companies. It just comes with the territory.
Mm-hmm. And there's a lot of compliments rolling in for you, Sheila. You have some fans watching right now.
I love it. That's nice.
But there's another question, actually. It's a good one. I know some nurses of color who stand to lose their jobs next week in New York, with the governor pushing to have all staff being vaccinated. Yeah. Some of these nurses don't trust the vaccine. How do you advocate or help these nurses?
Yeah, that's a huge problem that me and many of my colleagues and my team, we saw it coming. We knew just because you're a healthcare professional doesn't mean that you believe everything that has been out there about the vaccine, and that's really very, very sad. Mm-hmm. Help for them. I don't have the answer to that. I certainly don't have the answer to everything. It's education, it's resources. This COVID-19 has thrust us into a whole new world, and to lose your job because of that, that's pretty daunting. That's pretty difficult. So all I can say is that these persons, whatever decision they make, and it is a personal decision, they've got to understand the consequences of the decision and figure out where they can find support for their perspective or their opinion. Mm-hmm. And that's we're going to have to see how that plays out.
There's a lot of good questions and compliments here in this chat, so I'll make sure to save it all for you, Sheila. But another one, in terms of mental health and the higher demand that professionals are seeing due to current events, do you have advice for those seeking race-based trauma therapy versus a life coach?
Yeah, wow. The one psychiatrist that I've worked with, the Black psychiatrist of America, I've worked with a lot. And this one physician who is a forensic psychiatrist, he's the one that shared with me this new category of race-based traumatic stress. It's really very new. And I think people have to understand that healthcare professionals are just like everybody else. Just because they have an MD or a PhD doesn't mean they may not have racist ideas or racist attitudes. So you may have to take a minute to find somebody who's going to be culturally appropriate or culturally proficient in working with you. But there's even a bigger issue. Mental health is certainly a stigma in these communities. It's something that they're not willing to admit that they have a problem with, whether it's clinical depression or bipolar or anxiety. It's just not something many in these groups feel comfortable talking about. And the immediate response is, I'm not crazy. So, I think there's needs to be a lot of work in mental health being something that is just as difficult as diabetes or high blood pressure. It's just another condition. And there are treatments available and medications available, and usually a combination of the two, treatment, therapy, and medication. But you've got to find someone who can be understanding about your cultural space. And that brings me to this cultural competency. There are about 15 states when I last looked that require cultural competency training as a condition of relicensure for physicians.
Wow.
So this is not just an option or a nice thing to do anymore. It's a mandate in many areas, and Medicaid providers and Medicare providers. And so the cultural aspect of medical education is going through another revolution of change. Why is it that multicultural medicine isn't a required course in many medical institutions? It might be an elective, or it might be in bioethics. They kind of couch it in all kinds of euphemisms. But with the demographics being what they are, the fact that more than, by the middle of the century, 1 out of every 2 people will be a person of color or a person of color who speaks Spanish. Mm-hmm. How can you not have some education in multicultural medicine? So it's the health system is cumbersome. It's a lot of layers. It's very conservative. It's very resistant. And it's almost the antithesis of what makes multicultural marketing work. Mm-hmm. And physicians take an oath, first do no harm. And if you were doing something culturally that's wrong or would be offensive, I think you'd want to know. And I do a lot of cultural training of healthcare professionals. I've done cardiologists and psychiatrists and OBGYNs and pediatricians, and they're great people, highly educated people. They're frustrated people because they have a huge job and very little resources and time, but yet this now is got to be a part of their education and training. And of course, that's what they went to school for. So the education is not just with the patient, it's got to be with the healthcare professional too, because many of them are impacted by the racism, bias, and discrimination, which is well documented in the healthcare system.
You mentioned states where it's mandatory to have the cultural competency training. Is New York one of the states?
New York is one of them, and New Jersey is one of them. So people that are living in this tri-state area, it's a requirement as a condition of relicensure when you submit it. It may be 1 credit, but it's something. It's a start. Even health litigators, attorneys who are involved in health issues or health cases now have cultural competency training. It's running the gamut. How can it not, Sky? Look at the country. Right. I mean, if you don't have a comfort level with multiculturalism, I'm not quite sure who's your client, who are your customers. So it really behooves people to be comfortable, and it's uncomfortable. My team and I have a saying: we're here to comfort the afflicted, but afflict the comfortable. Okay, we got to shake things up. We got to be disruptive. If we're going to ever reach eliminating disparities, it can't be the same old, same old. That's not good enough. Not in this great country in which we're living, where everybody deserves quality health.
That's a great way to end this. You have a lot of good phrases, actually.
I've been doing this for a minute, Sky.
Thank you so much. I'm going to send you these compliments that came rolling in for you. Thank you to our live audience. And again, it's sheilathorne.com, but that will be also, this webinar was recorded. So all Sheila's contact information and everything will be on our YouTube channel, youtube.com/Schneps Media, where you can see a recording of this webinar. And Sheila will be in touch with everyone who participated today. So thank you so much for your wealth of knowledge and some laughs and some real talk. So
yeah, bold talk, courageous talk.
Yes, courageous talk. So thank you so much for taking the time to be with us. And thank you again to our live audience for being part of this, a courageous conversation about race, ethnicity, culture, and health in America. It's time for transformative action.
It's going to take each one of us to make a difference for all of us. So we're all in this together, regardless of where you come from, what language you speak, or what you look like.
Okay.
Okay.
Till next time. Thank you so much, Sheila.
You're welcome. Great talking with you, Sky. And thank you all for joining.
Yes.
Have a great day.
Thank you. On behalf of
Bye-bye.
Schneps Media, goodbye.